So with that, I thought it'd be great to look at some of our case studies and really look at some examples of when our diagnostics might not be totally accurate and how we can know that and manage that. And so some general reasons why this might happen is maybe we have undersensing or maybe we have oversensing giving us inaccurate estimates. We have to keep in mind the date range of our diagnostics, making sure we're looking at the period of time we want to and managing that. Device settings, we'll look at a couple examples where the way that our settings are set up to record episodes or store information might be leading to an inaccurate estimate of what we're trying to see. Also, other atrial arrhythmias, so someone going into flutter or atrial tach might be seen differently by the device, and we might want to manage those patients slightly differently in terms of anticoagulation, rhythm control, rate control. So just making sure we know what the actual rhythm is. And of course, a hardware malfunction could lead to inaccuracies as well. So with that, we're going to go into our first case study, and Trupesh is going to talk to us about this Biotronic report that we're seeing here.
Thank you, Kyle. So this patient has a Biotronic pacemaker, and he's also anticoagulated. So this transmission comes in with one mode switching episode lasting about 10 seconds. So it doesn't seem significant initially because he's already anticoagulated. But when we take a closer look at this episode, we notice on the top right, you see that the atrial burden is 0%. However, the duration of the mode switching is 34% of the day, or 1/3 of the time patient is in a mode switch. So let's go to the next slide, please. So right here, we are seeing that we are looking at on the top right, we are looking at the mode switch rate, which is set at 160, and the ATF detection rate is set at 333 milliseconds, which is 180 beats per minute. So that means the patient is having atrial arrhythmias below the ATF detection rate, so not categorizing them and providing any devices, not categorizing them as ATF and not giving us a ATF burden. So right underneath that, you see the EGM. The blue arrows point to the actual atrial events on the AGM. And the other signals that you see, it's from the far field, which are identified by the device appropriately. And as the far field, they fall into the far field protection window. However, before the mode switching occurs, you get this irregular heart rate when device is trying to track the atrial arrhythmia faster than the max track rate. So you see these irregular V-pacing rates that might be impacting the patient. Please move on to the next slide. So when we look at the HF diagnostics, if you look at the heart rate, the mean heart rate, one thing pops up on the left that for the patient's heart rate was around 70 beats per minute up until the early April. And suddenly the ventricular rate jumps to over 100 and the atrial rate is over 115. And this patient is pacing 100% of the time, suggesting that the device is actually tracking atrial arrhythmia rather than mode switching. So most likely the atrial arrhythmias are occurring at the lower rate than the mode switching rate of 160 beats per minute. Another thing, it's also, if you look at the thoracic impedance trend, it's right around the same time period started to go down, suggesting that patient might not be getting the optimal cardiac output, and it might be affecting patients' cardiac status. Please, next slide, please. So about 2 weeks after that report, the patient was actually upgraded to CRT-D device. And here, the important thing to note, it's the histograms. That's I have highlighted in the center with the red box. The atrial rates are 130 to 160 beats per minute. So patient did have atrial arrhythmia below the mode switching rate that was previously set at 160. But this device, the CRT-D device, is programmed correctly to 130 beats per minute, and the ATAF detection rate was also lower to 130 beats per minute. So now the patient is in mode switch, and if you look on the right-hand side, the mean heart rates have went down to 70 beats per minute, and device is 100% mode switch with the 100% ATF burden. As well as on the lower right corner, you can see that the thoracic impedance trends have improved. Next slide, please. So this is the presenting rhythm from the new device, and you can see the patient is still in the atrial arrhythmia, somewhere around 130 to 135 beats per minute. So clinic ended up lowering lowering the mode switch detection rate to 120 beats per minute, just to be sure that they are still mode switching with this lower rate atrial arrhythmia. Anyone have any suggestions, questions?
Yeah, I'd like to just add, like I like this case study because it shows how important programming is for devices. So the initial programming in the initial device wasn't malfunctioning. It was just programmed to look for AFib. And this patient isn't in AFib per se. But you think functionally, two of the biggest issues with AFib is, your lack of atrial kick, and then the irregular filling times also reduces cardiac output. And when we're trying to track every other beat because everything's falling into refractory and we're above the max tracking rate, we get that irregular filling time. So properly programming this patient not only allows us to know the true burden of the arrhythmia, but also improve patient symptoms as well.
Yeah, I also think this is a great case study, along with what Keith, what you said, the device isn't malfunctioning, but somebody could easily look at that first initial tracing and say, "Oh, this is an inappropriate mode switch due to, like far field R wave oversensing," and just end it at that, right? The episode's only lasting 10 seconds. But the device really is not programmed appropriately for this patient, but that takes a really kind of deep understanding of device function, right? Understanding what criteria needs to be met in order to mode switch. The difference between, what classifies something as atrial burden versus, mode switch, like why is there the difference there? So, what we talked about at the beginning, really understanding the nuances of a device function is critical in this particular strip to understand that yes, it's not a real mode, so it's not a real AFib episode. The device isn't malfunctioning, but we still need to optimize the programming for patient outcomes, because without those changes, you could see this patient was already starting to decline pretty quickly. So, good catch on your team and the device clinic here for making those changes for this patient.